Of our new fundamental nursing care document. It's going to be coming into circulation this week, and there are some key changes that you need to be aware of in how we're assessing our patients and how we're carrying out our documentation. I'm going to be here with Ellie today, who's going to be our patient, and we're going to simulate the journey of going through the document, how it's different, and how you can use it to the best effect. So as you are assessing your patient, you'll be able to see that there is a to E assessment, very similar initial assessment as to what you are used to. And there are some key additions, however, some recommendations, so what the nursing team have recommended in terms of the patient's care. And in addition to that, any additional documentation that's been started. So any additional care plans, any additional pathways, we're going to make sure that we've listed at the bottom of our initial assessment here. The new falls risk assessment allows us to identify our patients in a more meaningful way. What I mean by that is that if the patient scores, as it were, on any of the criteria, then we want you to think yellow. So following national and local guidance, we have introduced the yellow blankets and the yellow slippers that you're going to be able to place on your patient, which will allow further identification for everybody in the department that this patient is at risk of falls. So following on from my assessment, I've identified that the patient is at risk of falls, and I've ensured that they have a single-use disposable yellow blanket. Alongside these blankets, you may find a stock of single-use disposable slipper socks as well. These can't go in the laundry bins. They need to be disposed of through the general waste, and they must only ever be used for individual patient use. So moving forward with my assessment, the next thing that I'm going to be looking at is the trolley rail risk assessment. Now, this is a legal requirement that this has been introduced into our documentation, and it's really important that we follow it. It's a really straightforward, easy to use guide to indicate whether or not your patient's trolley rails are in their best interest. There is an element here that we can reassess as lots of patient journeys may progress within the department and change. So, next page, we're going to be looking at the skin assessment and body map. There is an expectation that we're able to fully examine our patient's skin top to toe within the first 4 hours of them being in ED. We're not just looking for pressure damage, we're looking for bruising, we're looking for burns, we're looking for all manner of issues with our patient's skin that can affect their skin integrity. A really straightforward body map here allows us to just quickly point out any differences that we find and any variance in that patient's normal skin integrity. So as a continuation of your body map, we then move on to the Purpose T pressure risk assessment. So moving forward after the body map, we're going to look at the Purpose T pressure ulcer risk assessment. It's essential that all of our patients start this process within 4 hours of being in the department. When assessing our patients, initially, we're going to look at their mobility status, their skin status, and we're going to be mindful of any clinical judgment that we may have regarding their skin integrity. If they're not at risk of any pressure damage or have no immediate pressure concerns, then we can simply tick that we have no concerns and move on. However, if we don't and the patient is at risk of pressure damage or worsening pressure damage, then we move on to step 2 and carry out the full assessment. By going through the different categories, you're able to score your patient appropriately. Now, if they score on any of the orange category, then we move on to the orange pathway. If they score on any of the red criteria, then we move on to the red pathway. Making sure that we've signed and dated before we move forward. The orange all red pathway needs to be completed within 6 hours of the patient being in the department. So moving forward, we look at the safeguarding and domestic violence screening, which needs to be filled out with every single patient. If we do have concerns with a patient's safeguarding status, then this allows us to navigate that much easier and gives us the information that we need moving forward. It is a legal requirement that we consider the safeguarding for all of our patients, so hopefully this won't be too taxing for those that we have no concerns for, but will be of massive benefit for those that we do. Now on the next page, we're able to document any cannulas and catheters to much better effect. There's a vascular access device, as well as the VIP scoring, which we'll be able to refer to. Urinary catheter insertion chart, which gives us a much more comprehensive view of the aseptic non-touch technique that we're going to be using. And in addition to that, if our patient has any central lines within the department, then we can note them and time of insertion here. As we move on, we're looking at how we are collecting our information during our intentional rounding. Hopefully that this new format will allow us to capture that information to greater effect and just make it a lot easier for us. So just as standard, we've got our checklist of different interactions of patient care that we are expected to give, but alongside that we're actually able to do the free text immediately next to it. So hopefully it's going to give us a greater idea of what's going on. It's going to make it much more accessible, and we're going to be able to capture the patient care that we give much easier. So I'm just going to whiz through the end, everybody. So there's additional space for you to write additional notes, because I just know how much you love to document everything that you're doing for your patients. All of the OBS charts, so our OBS chart, our neuro observations and our fluid balance chart, they remain in place. They will come out of the documentation eventually when we move on to patient track, but they are going to be there for the moment. All of those parts that we use every day also remain, so our discharge checklist, alongside our transfer risk assessment tool, our breakdown of news scoring and escalation, and I believe our S-bar there as well. I thought that it wasn't, everybody, and I panicked. But our S-bar handovers are also there.